The View. You've heard all the real talk. Now have a seat at our table. A table for five.
Good Monday morning, everyone. That stops fast.
It's loud, I'm sorry.
Oh, okay. She's going to go ahead and adjust. She's like on fire in her ears.
I'm good. Is that?
But good morning, everyone. Good Monday morning.
Live show.
Yes, it's live. Live and on fire today on this Monday, October 15th, 2019.
Yes.
Welcome, everyone. Welcome to Table for Five with Felicia and Annette. I'm Felicia.
I'm Annette.
And this is Annette. And today is the Doctors In
Yay!
segment with
We
Dr.
love this.
Kelly.
Yes.
Do a little crowd applause. Good morning, everyone out there. Just a little applause to wake you up.
Yes.
If you're wondering where you're at Table for Five, where you, the listening, viewing audience, will always have a seat right here at this table where we have lots of great conversations. We always welcome lots of difference of opinions, which you are, I think you might hear that today.
Yeah, it's going to be an interesting conversation.
We're going to have a fun show today.
Yes.
But before we jump into all that, I'm going to let Annette get you some more pertinent information.
Yes, our little housekeeping that we do every show to remind our guests and our viewers, listening viewers, where you can follow us and catch up with all shows past and present on our social media platforms, which are Instagram, Twitter, Facebook, YouTube, and our website, which I love to call our one-stop shop, where you can find out everything about us, about our upcoming guests, who our sponsors are, and how to advertise with us. If you are interested in advertising with us, there's a little tab there. You just click on it and someone very professional will get back to you. Also, if you would like to subscribe to our newsletters that go out twice a week, and all it is that it tells you who our guests are going to be and any links that are pertinent to the topic, and also gives you like a little tidbit of what's going on in the month. Like last month, Actually, today's the last day of Hispanic Heritage Month. Yep. So if you were receiving our newsletters, you would have gotten a little tidbit of information. And then also we are in Breast Cancer Awareness Month. And so we are including information about that as well and links for you to get more information. And you also could get a lot of information from our guests. So I would encourage everybody who's listening and watching to subscribe to our newsletter. It is really great.
Yep.
Really great.
Yep. We get you all the information.
Oh, and everything's www.table-for-5.com.
Yes.
And that's where you can get everything.
Everything is on that website.
Everything.
One-stop shop.
Yes.
But like we said, this is Breast Cancer Awareness Month.
Yes.
So I got my little pink on, my little pink lipstick. My
Oh,
pink
I didn't even
nails.
think about that.
Actually, I wanted to buy some pink scrubs, but they ran out. I was going to wear them.
Oh, because everybody's pink. This is if you are
You would
living
have
under
thought I
a
would have
rock
been on it like that. What?
and you don't know what we're talking about. October is Breast Cancer Awareness Month. And so it's the month that we talk about it and get more information out there. And I think it's really vital that we have these different themed months, because then we can focus on certain things and talk about them and shed light and bring more information and start more conversations about it, which is what we are trying to do today. So
And
go ahead.
No, I was going to say also with Breast Cancer Awareness Month, most women go and get their mammograms done and get checked. And today's show, we're going to really talk about that a little more.
Yes,
about
we're going to be in depth today.
The thermography and mammography and ultrasounds and all, and the differences and the importance of all of that. So we hope today's an informative show for you.
Absolutely.
And when we're done with it, please share it on all your social media platforms.
Yes, exactly.
And sorry to keep interrupting you. If you have any questions, we are on Facebook Live right now. So please, if you're watching on LA Talk Radio, you can go to our Facebook page at Felicia and Annette and write any questions that you may have about what we're talking about.
Yeah, jump in on the conversation if you have questions. This is our breast cancer show. So today's topic is Breast Cancer Awareness Month. And today on our Doctors In segment with Dr. Amanda Kelly here to my left, we are also happy to have Dawn Belden-Hope, CEO and owner of Thermography Center. And she is joining us via phone. Are you there, Dawn? Good morning.
Good morning. I'm so happy to be here. What an honor to be on the show with the two of you who until now I didn't know much about, but it sounds like you're doing a lot of good work in educating women, which is the key point for us, is that the women understand that they have choices and that we can do a lot in the world of prevention.
Absolutely. So we're going to have a great conversation today.
Yes.
So we're going to be talking with Dawn and Dr. Amanda Kelly about breast cancer and the different things that you can do to detect, prevent. It's going to be a great discussion. We don't have really a bio for Dr. Kelly.
Well, because I figured, she's been here once before.
Yeah. I'm not really a guest.
She's our
come in.
So just
our
to
co-host.
let you know, Dr. Kelly is here every month with us, doing a different medical segment.
The doctor's in.
The doctor's in. It's so fantastic.
I have real credentials. I do have it.
Yes, she is. An, practicing physician.
Yes. Emergency room medicine and phenomenal. So bringing her expertise to the table, and then I'm, as myself, and as we all know, have somebody that has been in our lives that has had breast cancer, that has been touched by breast cancer. And a little bit later, we're going to get real personal here. You want to tell people about that a little bit?
Yeah. Did you want to introduce Dawn? Because it was through her center that I got my thermography.
So I'm going to tell you a little bit about Dawn. Again, Dawn am I pronouncing your last name right? Belden?
You are. That's perfect.
Okay, perfect. Dawn Belden-Hope is the CEO and owner of Thermography Centers Radiant Health Thermography Incorporated. Since procuring the business in 2011, she has tripled the number of clients and opened new offices in order to support the growing demand for safe screening options and alternatives to mammograms. Dawn has been certified as a professional cancer coach by the Professional Cancer Coaches International and has achieved certification as the Advanced Imaging Technique Level 2 Clinical Thermographer from the American College of Clinical Thermography. So it's fantastic. So also, too, before I forget, if you guys have questions and you want to call in and you're not on Facebook and you're just listening to us or watching us, you have questions, you have comments to ask both Dawn and Dr. Kelly. The number to call in is 818-570-5085. Again, 818-570-5085. So again, this is a really important conversation that we want to have with you guys. It's Breast Cancer Awareness Month. Like I said, people in our families and our lives have been touched by it. And so we'd like to welcome both ladies to the show today. Let's get it started. Thank you again, Dawn, for coming on the phone.
So this conversation got started because about a month ago, I went in for a mammogram, which I hadn't done in 2 years. And so, my general practitioner sent me an email and said, hey, you haven't done this. It's about that time of year. Right. And so it was just a reminder to do some checkup. I go in, I have a mammogram, and about, I'm going to say 2 days later, I get a call, I get an email, I get a letter. It was like, da-da-da, all the bells started ringing, and they did find my mammogram was abnormal. So then they said, we need to have you have an ultrasound and also a secondary mammogram along with an ultrasound. But in the meantime, I had Felicia and then someone else, a lunch with someone else, and then a third person told me about thermography and getting that done to either confirm or deny, or just kind of get another opinion on what was the diagnosis that had come in through my mammogram. So I decided to do that because I heard it 3 times over. I said, okay, 3 is the charm. So I made an appointment with the center. And what you're seeing on your screens, if you're on, you're actually seeing my breasts. That's my breast. That's my torso. Yes, those are my boobies. And so anyway, so I made an appointment and I was able to get in, and lovely technician. My husband was in the room, and it's a very interesting kind of procedure. The room is very, very cold, and I'm sure Dawn can explain all the reasons why. And then there's like a camera. It's almost like a camera from a distance. You disrobe, you put your hands above your head, and they take these images that immediately come up on the screen, and they are able to, you can see them, but she doesn't read them. Someone else reads them and sends you a letter. When I told them that I had a scheduled ultrasound, so she kind of put a little bit of a rush on it, and a couple of days later they did in fact find and confirm what the mammogram had in fact found, that there was something there. So I did have to go and get an ultrasound. But I do want to say is that when I went to go to my radiologist to get the ultrasound, they were going to do a secondary mammogram, and I chose not to. And I told them I don't want to do that, and they were fine with that. They were saying, okay, it wasn't like you have to get it done. No, they were like, okay, not a problem. We'll just proceed with the ultrasound. Okay. And the ultrasound did in fact find a cyst that was debris filled. It was nothing to panic. It was no malignant, nothing to be concerned about.
How did they determine that? How did they determine that was?
I guess from the imaging that
ultrasound.
Yeah.
From the ultrasound.
The purpose of ultrasound is to basically figure out if whatever they saw on a mammogram or even thermography is solid or cystic.
Okay.
And an ultrasound, the way it comes up on the image, if something is cystic, it's like kind of black, you can see debris in it, so you know it's a cyst, whereas something solid looks different.
Yeah, that's exactly right, because it was like a black spot. Yeah, it's exactly. You're so smart. I knew you were here for a reason.
I told you I was real.
I know. And so anyway, so they did discover.
Well, and it is important for, that's back to the education piece, is that each screening has its own strengths and a little bit of weakness. So it's important that women, if they are choosing to use mammography, that they know that there are other options and the strengths and weaknesses of some of those other options. And, we feel pretty strongly that, trying options that are less invasive, that, less harm, and using the options that are a little bit more higher risk, less frequent, or discussing that carefully with your holistic healthcare practitioner. What are my options? How can I monitor my breast to make the best choices? And getting multiple opinions too.
Yeah, absolutely.
Dawn, when you say higher risk, can you explain what you mean by that to people who may not understand what you're talking about?
Yes, of course. So mammography uses radiation like CT and PET scan, which in certain times that's what we need to do. But radiating the breast over and over again, if it's an urgent kind of situation, that could be a good choice, again, depending on if your breasts are dense or if they're fibrocystic in nature. It's important to know which screenings read well for those kinds of breasts. But compressing the breasts at 5 pounds of pressure can spread existing abnormal cells, and radiating the breasts over and over again can increase your risk of getting breast cancer. So we have to be careful of that.
And it's interesting too, because I have to say that I didn't really know about thermography. I mean, when I was talking to you about it, Annette, when I brought it to you, I had just learned about it. And oddly, interestingly enough, I learned about it through my chiropractor. We were talking about it just because I've been seeing the chiropractor for the last couple months, and we were just talking about different approaches and mammograms. And I've only had one. I've had my first one, I think it was last year, 2 years ago. I don't remember now, but Annette and several friends were on me to have it. And I'm a little like, I wish I would have known about this, the thermography before I did my mammogram, not because I'm necessarily opposed to it, but I am from the thought process of, if there's anything I can do to prevent, I don't like to sit there and wait till something is wrong and then say, okay, let's try to fix it. If I can prevent things from happening, then I'm all about that. Like, I'm all on the prevention end. So I think that we need to do a better job of getting the information out there to know, for people to know their options.
So when
you
talk about like the risk of radiation with mammograms, I want people to be fully informed, because the types of mammograms, they've improved over periods of time. So the risk of radiation is a lot less than what it previously was. So you have to understand kind of what your risk is. So a mammogram is a little bit more radiation than like a normal chest x-ray. And you measure the amount of radiation in like millisievert units. People probably don't really know what that means. So kind of to put it into perspective, the mammogram is about 0.4 millisieverts. So that means, like, if you get a mammogram, you get the same amount of radiation that you would have over a period of 7 weeks just from background radiation, like
your microwave.
Carrying your cell phone.
Like that. But it is a risk, like Dawn said. But the same thing with like mammograms, there's false positives. Same things with thermography, false positives. So Dawn, my question to you is, what is the false positive rates for thermography? Because I would assume if you have a false positive in thermography, you're going to wind up having to have additional images, maybe ultrasound, maybe MRI, maybe CT. So you kind of end up in the same position. So can you speak a little bit about the false positive rates for thermography?
Of course, our false positives are not as high as mammography, but I think that's also because, they they're, how do I want to say, they want to be really extra careful. And so not that we don't want to be extra careful as well, but it's a little bit of, in and out, like, okay, come bring them in. There's a little bit of a system in place that's almost, over screening in a sense. And again, not if there's an issue there. It should be addressed. It should be followed through with. There should be, and follow-up screening as always. Even, for us, because, everyone makes mistakes. Our accuracy is about the same as mammography in most of the research studies that I've looked into, which is below 90%. However, there's still an error factor in that. So if there's a mass, and even if ours come back, I always tell them, even if this looks okay, if there's any change or if this hasn't resolved itself, this mass, you need to follow up with additional screening just to be certain, because we don't want to miss anything.
Yeah,
right.
Absolutely.
So with the thermography, I think the question that I have as a physician, since you own one of these centers and clearly you're more familiar with it than I am, are you recommending that people have thermography instead of mammograms?
That was my question.
Well, no. We can't go against the standard of care. Certainly not. I can say many women are looking for other options to screen their breasts, using thermography or ultrasound or even breast MRI. These three options are FDA and AMA approved as adjunct screenings. It's important to know that the only primary approved screening to this day is mammography. And so nobody can go against that, but it is important to discuss your breast health with your doctor and understand you have options available and what are the best options based on your current health and your family history, and as well as anyway.
Yeah, I was going to say family history, I think, was going to play a big part in it, too.
Yeah. So from my reading and research, I read that it is a pretty good, adjunct study, as you recommended. So, for instance, the U.S. Preventative Screening Task Force, they recommend mammography every 2 years. So a lot of people do it every 2 years versus every 1 year. But for me, my mom had breast cancer, so for me, it may be better to do, a mammogram every 2 years, but thermography every year to, increase my screening. So would you say that's like a good use of thermography, just to put it in perspective for people?
Absolutely. So there's less exposure, because if you're coming in, if you fall into a higher risk category, you said, you have a genetic predisposition, like a BRCA positive, or your family, your mom or somebody close in your family was diagnosed early, then they want you to come in more frequently. Well, then that's more frequent radiation exposure. And so if you're coming in every 3 to 6 months, that little bit of exposure becomes a lot of exposure over a 10-year, 15-year period. So you're right, in little bits, not so much. But so, alternating or depending on, again, do you have dense breasts, fibrocystic breasts? It's important to look at the different options that read the best. But yes, as a screening tool, as an adjunct.
We have a question on Facebook. Is there a recommended age for either thermography or a mammogram?
Yeah, well, I can talk about the mammogram, and I guess, Dawn, you can talk about the thermography. For mammograms, there was actually a little, I guess, the U.S. Preventative Task Force, they started recommending mammography at 50 when it used to be 40.
40, yeah.
Wow.
So they're pretty much in the U.S. the only, I guess, organization that recommends starting mammography at 50.
Everybody else is
everybody
what,
else, like ACOG, the American Cancer Society, other organizations, they kind of recommend 40. But in Europe, most people start at 50. And then you go up until like 70, 75.
Oh, wow. And then what about for thermography, Dawn?
At any age, I mean, I have young women coming in to get a baseline screening. You know, they won't be needing annual, but they want to have one set of images so that if something does develop, they can come back and compare to see if there's been any changes since their first baseline. One of the things that I've experienced in the last 8 years of screening thousands of women is this trend towards younger women and women trying to get in and get a mammogram and being under the cutoff age, and the doctor saying, well, no, you can't, you're too young, you're only 25 or you're only 28, well, you're fine. And so I have a lot of younger women just in the last couple of years that have come in because they've been refused, strangely, a mammogram because based on age. And then, you know, sadly, you know, too many early diagnoses of breast cancer in late 20s, and it's just very hard.
There's a lot of people in their early 20s that are being diagnosed with it.
Let's talk about that, actually, younger people being diagnosed with breast cancer, because there's certain groups that are in increased risk for developing breast cancer.
And I want to talk about the risk in just 1 second, because I know that our engineer is back at the desk, and if he can pull back up the images, I wanted to go back up to your images, if we can, for a second, because you said that in when you got the images done that it was detected, and I was looking at the images and I'm thinking to myself, what in the world? So where could you have seen
Dawn,
on those images?
Walk them through like how thermography works and how it picks up.
I was gonna say, what is the two differences between mammogram and
so just to be clear, like cancer cells, they grow rapidly, right? So the more rapidly something grows, you increase like the metabolic rate and like, I guess, like heat, for lack of a better word, radiating in that area. And cancer cells also, they require a lot of vasculature. So that's pretty much what thermography is trying to pick up. Dawn, I guess you could piggyback off of that to explain.
Correct. I mean, that's exactly that, cell proliferation. So that's that real early diagnosis. That's sort of a hallmark of thermography, is when the cells begin to proliferate very early on, then the heat differentials change, and we're looking at heat differentials down to the 0.00 decimal point, tiny little heat differentials. So it's almost a pre-screening, where most other screenings have to see something. They see, even if it's a small, tiny little tumor, in order to detect it, it has to be active. So we can see changes earlier than, you know, and is there a guarantee that will become a cancer? Maybe not. But if we start to have changes where our cells are beginning to proliferate, that's when we jump in, so we can help our immune system, you know, do the best job that they can to work to fight that, whatever's going on. Because cancer does flurry up in our body, and our body then takes care of it. It's when it gets out of control that, you know, unfortunately. And the other thing that I want to mention that we are able to see is a process called angiogenesis, and that's that new blood vessel supply. So when a cancer begins, is about the size of a dot. It cannot grow anymore. It has to have a blood supply to it. So a tiny little that is taking nutrients to that tumor and removing waste. And so we see those little tiny bits of, you know, of angiogenesis, that new blood vessel, which you shouldn't be growing new blood vessels to supply anything unless you're a nursing mom. And there's some changes in the breast.
The one thing that Dawn mentioned that I wanted to kind of expound upon, I guess, you were talking about dense breast tissue and fibrous breast tissue. So the reason thermography might be a good adjunct study for women with really dense and fibrous breast tissue is because when you do a mammogram, those type of breast tissues, it all kind of shows up like this fuzzy white. So do cancer masses. So it's really difficult to see masses sometimes. They can kind of hide with women who have really dense or fibrous breast tissues. So that's why thermography, I would think, would help with those type of women because it may be difficult to see on a mammogram.
And I don't think we didn't
absolutely
bring up
absolutely. Mammography is not a good screening tool for dense or fibrocystic breasts because the accuracy, I mean, it's too high a risk of missing.
Right.
So looking for that's another piece to discuss with your practitioner.
Another quick question from Facebook: are there any risk factors with thermography?
Good question.
Absolutely. I mean, it's difficult. There's DCIS and certain kinds of cancer, endocrine, that are difficult for us to see. And so there's no risk factors other than missing certain kinds of cancers, but it doesn't. There's no risk. It's zero risk. It's an infrared camera,
so I
think it doesn't emit anything into the body.
Right. I think that just to clarify something you just said, DCIS. So that's ductal. What does it stand for? Ductal carcinoma in situ is what you're referring to? DCIS. Yeah. So that basically is a type of cancer that starts in the duct.
Okay.
But
of the breast.
Yeah.
Okay.
It is cancer, but it's isolated to that duct and it hasn't spread anywhere, and it may not go on to spread anywhere, but you still kind of handle it. So she's saying that thermography may be difficult to pick up that type of breast cancer, but that's an early breast cancer, and it's easily treatable. So like she said earlier, you have to recognize the limitations of studies. I didn't know that was one of the limitations of thermography, but that's something to think about.
Well, because there's no activities.
Right, exactly. Exactly, that's what I was saying.
Function and physiology. That's our test. It's not looking at structure, function and physiology. So if it's active in there and we can see the activity, but if it doesn't move and it stays and there's no changes, and a woman could come in and have the screening, no change, and then again, no change. And if that's the case, we need to see activity. We need to see that things are moving or growing, or there's activity or there's changes, and that there's nothing to read in there, and it's encapsulated, so there's no heat.
Right, exactly. No, that's what I was saying. I was just clarifying what DCIS is. It's not like a life-threatening thing. It increases your risk of having invasive cancer later, but it's better to pick it up sooner rather than later. I was just talking about more so, like you said, the limitations and each study, just so people are aware.
So really quickly, because I know that we're about out of time with you, I know you have to go. I want to be respectful of your time. Real quickly, the difference between mammography and thermography. So I'm going to repeat it back to you in my understanding. Thermography, we're using heat, and we're detecting heat and light as through that, and mammography is strictly through radiation, and we're getting a picture kind of like how you would on an x-ray, correct? So those are the two main differences.
Correct, but thermography is just the heat. There's not really light. It's just using the heat from the body. So it's a very sensitive camera
is
that's
just
able
reading.
To see
it's using like infrared stuff. So I guess the best way to simplify it, how like you watch one of those weird military movies and they have like the night goggles on, and then you see something moving because it detects the heat of a human body. I think that's probably like
so thermography is kind of like night vision.
I mean, just for simplifying, going, you know what I mean? Just for simplifying it like
night
that.
Vision. Yes. But and also, may I just say, thermography is not just for your breast, correct? You could do a whole body.
Yeah, thermography's been around for a long time, but I think that people are just starting to make people aware that you can use it for breasts. It's been around for a while. Yeah.
And really quickly, I know you got to go, but why did you decide to open up a center? Why did you decide to get into this?
Well, I had it was one of those. I'm the kind of person, I have a background in education, so that's where my master's, so I was there for many years, and this is a full circle that I studied massage therapy and herbology and acupuncture when I was in my early 20s, and then I took a right turn, so I came full circle around, and I did teach a lot of modalities in virtual classrooms for years, and I was so interested in working primarily, and I'd customize curriculum. So I thought, okay, I want to customize healthcare plans. We need to look at the individual, and we need to figure out, what can we do to help them to see their bodies in such a way that they can then be their most proactive agents towards their health and direct them to good practitioners. And here's options for you to explore, and here's things that you can do for detox. Here's immune support. Here's, so that was really important. And but backing up a moment, I had a very, sort of mindless moment like we do at different times where we don't always do our homework, and we march in, and I found myself, I'm 40, this is what I'm supposed to do. And I walked in and I had a mammogram, and I thought to myself, for me personally, that it felt very barbaric, and I couldn't understand it. And I called all my girlfriends and I said, everybody's okay with this? I mean, for me, it just wasn't a good match. And I thought there has to be something else. Yeah. And so a few years later, so I went and I found thermography, and then a few years later, the woman who owned its father had taken quite ill, and so she approached me, and I said, "Oh my gosh, absolutely!"
That's
fantastic. 8 years ago. So for me, it's really, I'm not interested in making one wrong or one right. I'm interested in educating women, and I'm interested in prevention, and we're focused on breast health. How do we keep our breasts healthy? And you're right, with full bodies, a lot of full body scans. How do we keep our bodies, healthy?
Top shape. Did you have any other questions for her?
No. Thank you.
I know.
Dawn.
Are you at? I know we're out of time with you, Dawn, right?
Her information is on our Facebook page. The link. It's also on our website, www.thermographycenters.com. Is that correct?
Thermographycenter.com. You got it.
Yeah.
The Thermography
Center. So you can find out where they're located. They're everywhere and very easily accessible. It is a very pleasant experience, quite frankly. We're not squeezing you.
So would you do it again?
Yeah.
And you'll do it more frequently?
No, not more. I mean, I have to do it in 3 months, and then, of course, I just have to follow up on both ends. But now I know that there is a way to do it in between, your mammographies. To go somewhere where it's not so invasive.
Yeah. Well, we appreciate your time.
Thank you
Dawn.
so much,
Thank you
Dawn.
so much for being with us.
Thank you. Wonderful to be on with all of you. Enjoy your day.
Thank you.
Be healthy.
Thank you.
Thank you. Bye-bye.
Okay, so now we're in the midpoint of our show. We're going to do our quick commercial. We have a sponsor, Zavala Law Firm. Attorney Evie Zavala has been achieving exceptional results for his clients facing DUI and other charges for over 15 years. Evie has earned a reputation as the attorney to turn to in difficult and even seemingly unwinnable cases. His unique legal talent and courtroom intuitions obtain stunning results, vigorously protecting the rights and interests of his clients. If you need criminal defense, contact Zavala Law Firm at 818-987-7010, 818-987-7010, or visit www.zavalawlawfirm.com, and that also is on our website. So
yes, great attorney,
check that
great
out.
law firm.
I know. So now we're going to turn, because I want to have a couple of questions about just breast cancer in general. And so are the statistics... Are the statistics growing? Are we getting ahead of it? Are we still behind it?
Yeah.
Like, where are we at with diagnose?
I would say that since, I forgot, it was like the early 2000s. So breast cancer was like increasing. And then they found a link to hormone replacement therapy after menopause. And so when they saw that, they changed how they were doing hormone replacement therapy after menopause. So, the incidence of breast cancer started to decline. Okay. But I would say that it's probably still steady. About, you have a risk of about a little over 12% of getting breast cancer.
Is it, early detection is key? Like, I always find like, okay, so let's say.
Is it key, or has that aided in like the increase that we're seeing? Like, has it really increased, or are we just diagnosing it better earlier?
No. Let me look at the actual numbers, because the last that I read, there's not necessarily a significant increase in cases right now. I think what people were seeing a little bit that were making people nervous was a lot of younger women were getting breast cancer. So they were getting the like triple negative ones, or basically more aggressive breast cancers. But from what I read, there's not necessarily a huge increase in the amount of breast cancers. It's still like been pretty
So
steady.
is it preventable?
Honestly, I'm not like an oncologist or even a breast surgeon. I think there's things you can do to maybe try to decrease your risks. But I don't necessarily know that it's 100% presentable. I mean, we still haven't found a cure for cancer. So I don't think there's a great understanding of how we could 100% prevent it. So the biggest risk factor for breast cancer obviously is being a female and age.
Okay, and genetics.
But
genetics only have only 10 to 15% of breast cancers are genetically linked. 80 to 85% of women who get breast cancer have no prior history.
Wow.
Yeah, I didn't have.
That's very interesting.
Not that I have any breast cancer, but I mean, of course, there was nothing. There's nothing. I mean, we went back as far as my grandmother. Nothing. There was nothing for us to be like, But I wanted. You said female, but I wanted to say men get breast cancer.
Absolutely.
Now,
less than 1%.
Less than 1%. But how do they detect it? Is it the same? And can you really put a peck in a machine? I mean, how do they get checked?
Yeah.
No, so that's the thing. Like men actually have a delayed diagnosis because it is difficult to detect.
So then it being delayed, does it mean it's far gone?
It's probably more advanced, when you detect it in men because they start having symptoms, like breast pain, tender, redness, nipple discharge.
So they don't have a requirement to have their
it's like
chest, pecs.
There are some risk factors for men that I actually did look up.
Lord Jesus.
Question.
So I'm wondering, that might be that would have been a question for Dawn.
Should men get thermography?
Yeah.
Yeah,
because
that'd probably be a quicker, an easier test for them versus, I imagine an ultrasound would be what they would get.
They can still
they can get in a machine?
It depends. So some men are on medications that cause them to develop breast tissue or like fattier tissue. So if men have large breasts, they can get a mammography.
Like they can squeeze it in there. Like
that is
you might have enough for
like
but listen, men, I would not recommend it because I did one and it's not fun.
It's horrible.
So
I'm sorry, ladies, I have not had a mammography yet.
The doctor in the house.
It's not time.
It's not time. Whatever. But no. Okay. So here we go with the age situation. So being that there is a little statistic that says younger women are getting, wouldn't the age go down?
Not from mammography because you still have the risk of radiation. So, like,
what about thermography then? Do you think that's a good alternative then?
The key that Dawn said. So you have to. There's risk and benefits to everything. So if you're, 25 years old and you start going for thermography, there's a higher incidence that you're going to have a false positive, right? So then you find something and it's probably not going to be cancer, and then you may wind up getting ultrasounds or MRI or something else to make sure that it's not cancer. I agree with what she said, maybe like a screening thermography.
Like a baseline.
So you know what it looks like. So if you find something abnormal, you go back and they're like, yeah, this is definitely a change. So like if you have increased risk, so somebody like me, like I have a first degree relative who had breast cancer, my mom. And then also my mom's aunt, so my great aunt, she actually had breast cancer, but she was like 70 something. Like she just had breast cancer. So maybe it would be a good idea for me to get a screening thermography.
Like a baseline.
Like a baseline. But like in general, I'm probably not.
Yeah.
Not routine thermography. I wouldn't think so, but I mean that's a better question for Dawn. But for men, getting older is a risk factor. High estrogen levels. So like if you have liver disease, you have problems clearing your estrogen, so that gives you higher estrogen levels. Some medications that you take, and being overweight, you increase your estrogen levels. Using alcohol. Those are the risk factors for men. And then I know some psychiatric medications, well, this goes back to medications, they cause like gynecomastia, so men to develop breasts, so, those type of things.
So I think
if you see a man with breast, run, because he's got some mental condition.
Oh my God, that's awful.
That's one of the medications.
I just needed to bring some levity. I wanted to ask you something that we were talking about off the air, which was... oh my God!
The BRCA test.
The BRCA test, and where full what do you call that? A mastectomy is a good idea.
Yeah. hold on. Before I'm gonna let you think about the answer to that question, we're gonna talk about the BRCA, and the BRCA test is the BRCA gene test is a blood test that uses DNA analysis to identify harmful changes, mutations in either one of the two breast cancer susceptibility genes. BRCA1 and BRCA2. This may or not be associated with the increased risk of breast or
BRCA
ovarian
is a
cancer.
gene. So with any cancer, there's a receptor or a gene that malfunctions.
Right.
There's something to cause it. So with BRCA1 and 2, they increase your risk. I think it's anywhere from like 40 to 50%. One of them is like 45%, BRCA1 or 2, and then the other one's like 40 to 45%. I forget which one is which.
Okay. And so the blood test can detect whether or not these genes are positive. Is that correct? That's what we're looking for.
They also, I forget, is it BRCA1 or BRCA2? They increase the risk of ovarian cancer as well.
Yeah.
So it's kind of more of a personal decision if you want to have a radical bilateral mastectomy. You have to have an informed conversation with your provider and make that personal decision, because some women love their breasts so much they're like, I'm okay with taking that 45% risk, and they will not have a mastectomy. And there's some women who are like, I don't care, I want to be around for my kids, so I'm gonna just take them off. But with that said, I think surgeons do their best to remove all of the breast tissue, but sometimes there could be residual tissue left behind under around the muscle or something like that, and you still may have a very, very tiny risk. That being said, you took your risk from 45% down to like maybe 1 or 2%. So
yeah. And I think too, would you recommend or give the advice to people that it's good and okay to get more than one opinion?
Absolutely.
Like, don't just go to one person or one doctor.
Absolutely.
And if you have a diagnosis, like, I would say do your research. I know it seems daunting, and if you're in the middle of a diagnosis or you've just been newly diagnosed, it's very scary. But search it out. Talk to other people. Talk to people that have had it done. Get different opinions and see different doctors and alternatives.
Everybody has different experiences. When my mom got diagnosed with breast cancer, I was, third or fourth year resident. And I remember I worked the overnight shift, and I drove all the way from Philadelphia to New Jersey. I normally don't drive when I work overnights because I had a little boo-boo my intern year. But I was like, this is a good reason to do so. Yeah. And I went to the doctor's appointment with her, and my mom had a really good primary care doctor. She said, she made it easy for her. She said, here's 3 breast surgeons that I recommend. They're all very good. They're all very qualified. Meet with all 3 of them and choose which one you're more comfortable with. And so, her doctor kind of helped her with that. If your doctor doesn't help you with that, you have to do the research on your own, which sometimes can be a little overwhelming. But do some research, find a hospital network or somewhere where they do a lot of breast surgery. That's the thing with breast surgery. You have to make sure they do a lot of them and have a lot of experience.
If you're going to go that route,
right? I mean, honestly, if you have something that's invasive, you probably don't have a choice. You have to probably get a lumpectomy, but that's out of my scope of practice anyway. But if you have to go that route, you can talk to multiple surgeons and see, who you're more comfortable. I definitely recommend talking to 2 or 3 to see who you're comfortable with. For sure.
Yeah, so get second opinion. So what do you, go ahead.
Well, once you make the diagnosis, so the only way to 100% say that you have breast cancer is a biopsy. There's no other way. Thermography, radiography, CT, whatever, they can all say it's suspicious for, this is what it looks like, but the only way to 100% to do it is to take the tissue and do a biopsy.
And test it.
That is it. So I'm talking about at the point where you already 100% have the diagnosis.
Okay.
So second opinion, sure, do what you want, until it's proven, but once you have a biopsy, it's there.
It's there. You got to deal with it.
Yeah, I mean, I have a great team of doctors, and I was fortunate enough to be referred to a breast center. I didn't go because I just didn't go. I wanted to stop.
See,
my little boobies.
Everybody here.
2
years ago they were on me.
I'm sitting here with 2 Hispanic women, and I'm African American. Hispanic women, you guys.
She's not Hispanic.
No, I'm mulatto.
For real?
Yes.
This whole time I thought you were Hispanic. My bad. See what happens when you
Is
mix
that why
with
you
stuff?
said that earlier today?
What?
You were
Hispanic.
like, people of Latin descent should
Yeah,
not.
I 100% thought you were Hispanic. Sorry.
It's all good.
See, education is key.
Yes.
My apologies. On the mulatto
Good,
side
you're
of the
good.
family. I forgot what I was saying.
The Latina.
Oh yeah, like you guys have lower rates of like mammography screening.
So that community doesn't go and get.
You need to go get your mammograms.
Yeah, no, I mean, thankfully we
And
have
thermography.
and thermography, right? Yeah, no, I mean, I'm very diligent about my health care. Thank God, my parents were very diligent about our health care. So we go. And so, but in my last mammogram, they told me you don't have to come back until 2 years. Like they didn't say come back next year. So that was kind of nice, and they're really good about, okay, it's that time of year. Yeah. You have to do this, and this. And so that's when I said, okay, let me make all my appointments, go in, and the other thing
go ahead.
I haven't done is a colonoscopy because I'm that age.
Oh my
and
gosh.
I ain't doing it. And
2 years ago, I was getting a bunch of
Why?
flack for not
That
getting a
doesn't even make
mammogram.
sense. Like colon cancer is so preventable.
Yeah, so preventable.
And
you need to go get it done.
They put you to sleep. They can put you to sleep.
Before we run out of time, though.
I know they do.
This is before we run out of time. I want to talk about going back and speaking about ethnicity. I wanted to talk about, is there a different risk factor per ethnicity? Are African American women at higher risk than Latino, Caucasian, Asian? Like, how do we? Where can we? Is there a chart of who falls into?
There are plenty of charts if you care to Google. There's plenty of graphs and charts that you can look at. White women by far have the most incidence of breast cancer.
Wow.
By far.
Really? Interesting.
Well, I shouldn't say by far. A smidge higher than black women.
Okay.
However, black women have a higher risk of dying from breast cancer than their white counterparts, and also black women get diagnosed later, or when their diagnosis is more advanced. And then black women have a higher incidence of triple negative breast cancer. So,
and is that because they don't do the mammograms?
No. Triple negative is, so when you say triple negative, you're referring to the receptors in the cancer cells themselves. So there's estrogen, progesterone, and HER2. And if you are positive for these receptors, there's medications that treat these types of cancers very well. So basically, you get the biopsy. When they do the biopsy, they use certain type of testing to tell you which receptors you're positive for. And then once they decide that, they're like, oh, great, perfect, we can treat with these medications. But if you're negative for all of those receptors, there's not medications easily available, and then they have to come up with other alternatives, chemo, radiation, whatever. So and then the triple negative ones tend to be a lot more aggressive. So black women tend to get that, and younger women tend to get the triple negative cancers.
Oh wow.
So and they used to say it was because the disparities and like the more advanced breast cancers, or the more aggressive ones, being more present in Hispanics or African Americans, is because of like access to care and like getting mammograms and things like that. But now that's not true. There's 69% of African American women got mammograms and only 63% of white women. So it's like, no, we're going to get our screening now. So that's really not the issue.
More aggressive.
So they try to link some risk factors to like reproductive stuff. So like how old you were when you had your kids, how many kids you had, how old were you when you went through menopause, are you overweight, like those type of things.
Breastfeeding and all that other kind of stuff.
Yeah. Okay. Like white women are, I almost said supposedly, are more likely to breastfeed their children, so they have less of a risk, whereas black women are less likely to breastfeed, so that increases their risk. Like black women tend to have more fat around their abdomen, so that increases your. I mean, there's a bunch of things that they're looking at to try to figure it out.
But I would encourage people to look into that and think about that, because I do think I don't want to say that it's preventable, but I do feel like that we should all be taking steps in our life to decrease our risk just in general. And as a woman, as a female, maybe you can speak about, I don't know if you know, or maybe we could talk about if there's anything that we can do to decrease our risks, like deodorants. Like I know personally, I have tried to take out the deodorant that has aluminum in it.
Do you smell?
Well, I've had to go through 3 different kinds. I don't know. You tell me. This one today is working pretty good. I would not suggest doing it in the summertime. But yeah, I mean, I think anything that you can do to decrease your risk, to me, and if you have, I think if you have a susceptibility or if you have a history of it in your family, I would encourage people to go get the BRCA test. I think knowledge is power.
Knowledge is power. So for me, I didn't get the BRCA test. I flat out asked my mom's breast surgeon, do you think I need to get the BRCA test? And she was like, no. So, I mean, it depends. You know, I'm not a breast surgeon. I don't have all the expertise, but I think people assess your risk and see. So, like, the next time I go to, like, get a checkup, I'm actually due. I would sit down with my doctor and go, hey, you know what? My mom had breast cancer at this age, and then her aunt had breast cancer at this age. Do you think I'm at increased risk? Should I consider genetic testing? It's just a simple question to ask.
Start the conversation.
What your risk is. There's nothing wrong with asking.
So let me ask you something. Do you think that her removing the aluminum from her deodorant is a
I mean, I haven't seen any studies about it. I've heard people saying that, you know, removing the aluminum from your deodorant, basically what you're trying to do is decrease your exposure to carcinogens. Carcinogens are things that increase your risk for cancer. But I mean, honestly, it's like
everywhere.
Everything. Yeah, it's like they're everywhere. They're everywhere.
They're in our, we're sitting in front of them. We're holding them. We're eating out of them.
If I can do one less thing and not putting it on my pits.
Yeah, if you could do, I'm gonna do it. If you could do one less thing, if you find a research study or you talk to your doctor, I mean, what I would say is, you know, research is difficult to interpret. I mean, honestly, there's so many research studies, and it's like, is it a good research study? That's the question. Like, we literally sit. And I used to like look at articles and we rip the articles apart because they're not always good research studies. But if you come across something that says, this is a carcinogen, maybe you should try to do less of this, ask your doctor about it. And even if they don't know, if you have a good doctor, they'll look it up for you. So like, you know, just ask questions. I mean, there's so many carcinogens. Like they were trying to say it was in coffee. And you know, I'm like, all right, eventually I'll die from cancer if I live long enough. I mean, honestly, that's the way I feel about it. Like, the longer you live, the more likelihood you're going to have some type of cancer.
Sure.
Period.
True.
Exposure. Yeah, it's this constant exposure that we have. So, I mean, I think if you do something in a smaller way, but it's, you know, it's a monster of...
It is, but I think we have to be aware of it, and if we can try to change things and do things,
like
you know,
like smoked food. No, there's carcinogens in that. So I mean, it's like, okay, well then don't eat smoked food. I mean, you have to make these choices for yourself and how much risk you think you want to take. I live on the edge. I'm like, listen.
She's over here on the edge.
No, I am, because I am a physician and I recognize that I have the ability to perhaps change the course of things, but that's only because of the man upstairs. So if I'm supposed to have cancer, then eventually I'll get cancer. So I live my life.
Gotcha.
That's just me. That's my personal decision. Clearly, you're different. You don't like aluminum.
I'm not putting aluminum in my pits.
Okay.
I would suggest you don't.
Just
and go get a colonoscopy.
Oh yeah.
You need a colonoscopy.
Oh my gosh.
That's another type of cancer. So you have to understand, there's some cancers that have absolutely no screening tools, none whatsoever. So like lung cancer, there's no routine screening tool that I know of. I mean, clearly you can get CTs, chest x-rays if you're at higher risk, things like that. But I mean, colon cancer, cervical cancer, those are cancers that there's easy screening tools. Mammogram, you know, breast cancer, take advantage of it.
Yeah.
All right, if I do, I'll let y'all know.
I mean, at the end of the day, the benefit of a colonoscopy, besides detecting cancer, is that it's almost like a colonic. You drink that Go Lightly, it all comes out. It's all clean.
That Go Lightly.
Well, I've done a colonic, if I want to just put that out there.
This is what I'm saying. So you get 2 in 1.
If you did that, then
and I was awake for that.
You get 2 in 1.
Yeah, I agree.
Yeah,
well, we are out of time.
Oh my gosh! Oh my gosh! Yes, we want to thank. Did you want to add anything else to Breast Cancer Awareness Month?
I think we talked about. I think everybody knows that breast cancer is an issue.
Yeah.
Yes.
I don't think I need to recite the numbers and all that stuff. Everybody knows that, and I think a lot of women.
Oh, I know what we wanted to. I'm sorry, really quick. We talked about self-exam.
Okay. Yeah. So there's been like controversy about whether you should do self-exam or not. Like some people feel like it's not helpful. You just find stuff and then they create false positives and all those things. And some doctors absolutely recommend it. I would say the more familiar you are with your breasts, the better. To be
or somebody, your husband.
Because No, it's true.
Listen, there are husbands out there.
It's true
that are willing to give
the way
breast
you should
exams.
examine the first things first is look. So you stand in the mirror, shoulders even, shoulders back, and look at the breast and get familiar with the way your breasts look standing up. And then you examine.
The lower they get, does that mean?
That just means you know.
Damn it.
So then you can you need to do the examination laying down and sit up, and you always want to put your arm behind your head like this, and you want to do it in a routine way, so you're covering every portion of your breast, and you want to use kind of like the pads of your fingertips, and you want to do like this is kind of awkward, like firm. Touches. So you can either decide to go up and down the whole breast like this, or if you want to go across this way.
But you should do it laying down.
And standing up.
Oh, okay.
Because if you change position, it change. Like you can see, like when you pull up, you pull your breast tissue up, and if you just like relax laying down, it's different.
Got it.
And so you gotta feel it in all ways.
Examine under your armpits too, because breast cancer can spread to the lymph nodes, so they can get abnormalities and swelling or masses under here as well. And then you want to also examine your nipple, make sure there's no discharge, or like your nipple's not inverted. I mean, some people have inverted nipples at baseline. Just if it's a new finding, then that's a problem.
Right. So get familiar with what they look like, how they feel.
Right. And if you should do it the same time every month. Usually the best time to do it for women who are still having their periods is like a couple of days after your period, because
after you start your period? After you finish?
When you finish.
Oh, you finish.
Because like when you get your period, you get like fibrocystic changes.
Right.
You get
Everything's
like
really tender.
They're usually around this area, like around like your upper outer portion of your breast. They get all tender and things like that. So the best time is to examine like a couple of days after your period.
Okay.
So,
good advice.
Yeah, I was just going to ask you one other question, and it just slipped my mind. Oh, okay. Well, I guess when she comes back, we'll just piggyback from there.
Yes.
Okay. Yes. We want to thank you, Dr. Kelly, for joining us again. The Doctors
fun.
In segment.
She'll
Thank
be
you.
back next month.
Yes, with another interesting topic. We don't know what that will be.
I forgot what we're doing.
I know. I don't either. Our trusty associate producer will let us know. We want to thank you for watching. We hope you've been informed, educated, and entertained. We'll catch you on Wednesday. We have a political show. It's going to be really interesting. Don't miss it.
Ooh, what y'all talking about?
Politics then and now.
Okay.
Lord have mercy.
Yeah, should be a little spicy.
Did you see that interview with the First Lady?
Oh, yes.
I should have talked about that.
Yes.
I didn't see it.
But yeah, you're going to have to watch it.
I just saw the Kanye West.
Yeah, no, and that too, that part. Okay, so catch us on Wednesday. We'll be back. Thank you for watching. Have a great
week.
Bye.
I'll say this.
You're listening to Table for Five with Felicia and Annette, only on LA Talk Radio.